Before I introduce myself, I'm going to start by acknowledging the traditional owners on the lands that we're meeting today, the Aranda people, and to acknowledge the traditional owners of the people of the land that I'm living on at the moment, so the Larrakia people, and to the traditional owners of all the lands that people have come from today. I acknowledge all the First Nations people in the audience here with us. And I want to pay my respects to elders past, present and emerging. And my sincere hope for today is that it's their stories and voices that are heard loud and clear in all of the conversations that we have, and that we can take those stories and voices and echo them as we leave. So it's in that context that I wanted to start the conversation. My name's Ruth Derkenne. I'm the Director of Medical Services at Top End Primary Healthcare in Darwin. We provide healthcare to all the government-run primary healthcare centres in the Darwin remote region. I think I was volunteered to facilitate this session this afternoon by Christine Connors, so thank you to Christine, and I acknowledge Christine and all the work that she has done with Menzies, Diabetes Through the Lifecourse, and the Summit and the Collaborative so far. I think understanding people's stories and where they've come from is really important, so I'll just tell you a little bit about who I am. I grew up in Newcastle, in Newey, for anyone from, oh yes, on my table even. And then came up to the Territory to do my postgraduate training, so my GP training and obstetric training. I thought I'd only spend a few years, like most people do when they come up to Darwin, but fell in love with the lifestyle and working in remote Aboriginal communities. I worked in Darwin, a little bit in Katherine, and spent a lot of time in East Arnhem. And I feel like that really changed the course of my professional career and my life. I then went on to work in the Torres Strait, and then decided to go overseas to do some study in tropical medicine, and met my husband, who's French and American, and then we ended up working in Guyana in South America on some medical programs. I worked establishing a maternal health program, and we were able to reduce maternal mortality by 50% and had really sustainable change there. And it was the local people who then continued to run the program, and we were able to come back to Australia, where I now live over the fence from Louise. Our chickens are neighbours. And so I tell that story, my story, and I think it's important that everybody gets to tell their story, because it's in telling stories that we find connections with people. So when I met Sean and found out that he was from the Torres Strait as well, automatically there was a connection because I had lived and worked in the country that he was from. And the same when I met Peggy just last week, knowing that I knew the land that she had come from, or the waters that she had come from. And so I hope that those connections can really be strengthened around the tables today, because it's connections that form relationships, and relationships can be really powerful. We've already heard that today. Relationships can be therapeutic. They can build resilience and help promote healing, but they can also be really powerful factors for change. And I think we saw through the COVID epidemic how all coming together and working towards a single aim helped us to, I think we had the lowest death rates from COVID amongst First Nations populations than anywhere in the world, because of the relationships and the actions that we all took together. So if we can harness those relationships and actions to focus on diabetes, how amazing would that be? Which is why we're all here. The session today, we don't have the topic. The session today is, what is it? Coming together for meaningful outcomes. When they asked me to facilitate the session today, I thought, oh yeah, it'll be a group of 30 or 40, 50, 60 people. That can't be too hard. But there are over 200 people in the room. Well, there was this morning. We might have lost a few along the way. But over 200 people from all corners of the NT. So there were people here from Nathan from Gallawinku, Mary Claire from the top of East Arnhem, and people from interstate. So people have come from far and wide, and we have politicians and policymakers, heads of health services, and people who live here. People who live here, yep. The fact that we have so many people in the room, I think, is a real tribute to the respect and recognition that people have for the work that Menzies and Louise and her team have done over the years. And so with that, I want to hand over to Louise now to talk about the work that they've done and their research.
Thank you, Ruth. I am just going to talk relatively briefly about some of our recent work and then hand over to others from our Diabetes Across the Lifecourse partnership. So our partnership has been going now since 2010, and so this is our 11th annual educational symposium, which is fantastic and a great thrill to have everyone here today. We did continue the symposium throughout COVID in smaller ways, more online, and it's so good to be back together with more in the room now. So thank you everyone for coming, and particularly this one is exciting as the first NT Diabetes Summit, and having all our partners here partnering in the summit is excellent, so looking forward to it. A key part of our partnership are the partners, and particularly two key advisory groups, being our Aboriginal and Torres Strait Islander Advisory Group, chaired by Sian, who's been leading the program today. Particularly this morning's program was fantastic. Thank you, Sian, and all the advisory group members here with us today. And then another key group in our partnership are the Clinical Reference Group, which has been a key group from the beginning and has been chaired by Christine Connors ever since the beginning. This is the first year Christine is not here, and she's handed over into very capable hands. Ruth Derkenne, as you've met Ruth, and the Clinical Reference Group have been key in advising and guiding on priorities of the partnership. And so this traditionally, we have met in the afternoon with the Clinical Reference Group and the Aboriginal Torres Strait Islander Advisory Group to come together to discuss priorities and next steps and key findings and learnings from our work so far. So just briefly, some of our recent work. This is our partnership started as the Diabetes in Pregnancy Partnership, which I'm sure many of you are familiar with. And this are the key elements of the work in diabetes in pregnancy here that we've been doing since 2011 with key partners, particularly NT Health and AMSANT as key service delivery, or AMSANT working with other archers in service delivery and policy making. And so key to the partnership has been this work in diabetes in pregnancy, particularly working with clinicians in developing capacity, upskilling clinicians, but also improving and streamlining our clinical guidelines. And so really this has been a complex health systems change that we've been involved in with multiple components there outlined on that slide. And then some of the impact of the diabetes in pregnancy work. So particularly it's a data-driven approach using our diabetes in pregnancy clinical register that now has over 2,500 women from the NT, and then is also in Queensland now with over 1,500 women from Queensland. Some key work that we use the clinical register for is bringing clinicians together to engage in discussing the results and how we can learn from those results, identifying gaps and improving services, and particularly bringing primary care and hospital level services together to look at the shared data from antenatal and birth outcome data in the clinical register. So some of the findings early on with the clinical register, we saw an 80% increase in reported rates of gestational diabetes among Aboriginal women in the midwives data collection. That was most likely due to raising awareness and then increased screening and reporting of gestational diabetes. And then we've since seen something really quite likely similar for youth diabetes in recent years that I'll get to in a minute. And so then some of the outcomes really from our diabetes in pregnancy work that has translated into changes in how we do things, just a few examples. So now Dr. Anna Wood here with Dr. Dana Mackay started a weight management clinic in Darwin and Palmerston hospitals, and also the obstetricians have started a preconception clinic. So really a lot of our work has focused and highlighted on the importance of the preconception period and also the importance of maternal weight as an opportunity for prevention and early intervention to improve outcomes both for mother and baby. And then other models of care changes. Dr. Matt Hare is here today. He's been involved in changes in remote telehealth and antenatal models of care as well that have evolved in recent years. So there's been a lot of other changes in models of care. The current work particularly is focused on youth diabetes, led by Dr. Renee Kirkham here and Dr. Angela Titmus at the back there, a leading work in youth diabetes models of care as well, with many of you in the room, and particularly leading with the ARCHOs as well. And then another key part of our work is really advocating as a result of some of our findings, advocating for change in policy and practice. So Christine Connors and I have done a lot of work meeting with the NT Health Leadership Committee, different levels of government and ministers, and the NT Diabetes Network as well has been strongly advocating for changes in policy and practice that we feel are important as a result of some of our findings from our work. This is the youth onset type 2 diabetes data. This is data from the NT Aboriginal Health Forum, key performance indicators that was shared with the NT Diabetes Network for the purpose of raising awareness around these alarming increase in rates of youth onset diabetes. So this is youth onset diabetes in Aboriginal youth aged 15 to 24. And there's been a 100% increase here over the past 6 years in those rates. So that's incredibly alarming that not only do we see such high rates of youth onset diabetes, but we are seeing dramatic increases in those rates. And so that really is the focus now of a lot of our work, is the youth diabetes, and as we talked and heard about this morning, a really important area of future work. So just an example of some of the work in the youth diabetes space are these screening guidelines that Dr. Angela Titmus and Dr. Dana Fitzsimmons led for the NT Diabetes Network. And they really were quite groundbreaking nationally as guidelines for screening for youth onset type 2 diabetes among Aboriginal and Torres Strait Islander children and young people. These guidelines were then incorporated into national guidelines and published in the Medical Journal of Australia by the Australasian Paediatric Endocrine Group that Angela Titmus is involved in as well. So these are really important guidelines that are now in practice and policy here on the ground with all of you. So just to finish with the vision and the priorities of Diabetes Across the Lifecourse partnership. The vision is around working in partnership with Aboriginal communities to break the intergenerational cycle of type 2 diabetes. And there are 3 priorities there. Firstly, around prevention and management with a particular focus on young people, but also across the life course. And then around strengthening community engagement, particularly again across the life course, but again focusing in the pregnancy and preconception and youth time periods of life are key. And then the final priority is around strengthening the Aboriginal community-based workforce in diabetes, as we heard from Amina earlier about the AMSANT Yarning Circle findings. That was key there as well, and is an ongoing priority. So here's our recently revamped slide of the Diabetes Across the Life Course partnership on a page, with families and communities at the centre, and our Aboriginal and Torres Strait Islander advisory group, they're key, as well as obviously community engagement and knowledge translation and lived experience playing a key role there. And then the life cycle around that and all the key points of the life cycle. And then on the right, all the projects currently involved in our Diabetes Across the Life Course partnership. So a large number of projects and a large volume of work, which takes a huge team, and virtually all of the team are here in the room today. So an enormous thank you to all the team who are continuing to lead the way in this great work. And I have to say a particular thank you to Norlisha sitting there, who's been running around all day and organised today, and and also did this slide and is multi-skilled as our lead in stakeholder engagement. So thank you, Norlisha. And on Twitter right now. And I will end there. And I will introduce Sian Graham as chair of our Aboriginal and Torres Strait Islander advisory group and working in true partnership. We're up here together, but I'm going to hand over to Sian.
Thanks, Louise. Oops, sorry. Thank you. So thanks, Louise, for that. So the partnership has come a very long way since the beginning in 2011, where the partnership focused more on health services and clinicians. Yes, this is important, but the missing link was the community level voice. Over time, we've shifted our focus back to communities and are creating a platform where communities can identify their own issues and their own priorities to inform our future research. So it's important that we have Aboriginal and Torres Strait Islander voices and representation to provide our perspective on how to work with our communities and our people. It's important that we strive for working in the most culturally appropriate way and ensure our communities are going to benefit from our research. We need to lead this, especially when our people are at the forefront of this diabetes epidemic. So the partnership established governance groups, as Louise mentioned, from commencement, including a clinical reference group, a steering committee and an investigator group. There were Aboriginal and Torres Strait Islander investigators and members of these groups. However, there was no group representing urban and remote communities. In 2017, we identified a strong need for this, and a strong need for an Aboriginal and Torres Strait Islander advisory group was identified to provide strategic advice and cultural knowledge concerning all aspects of the partnership. So we currently have 10 Aboriginal and Torres Strait Islander members, and 4 are here in the room with us today. So members live and work in Darwin and Alice Springs and continue to have strong connections within their communities. Each member comes with a great understanding of health, community-based and cultural knowledge, and a good understanding of research. This enables the advisory group to provide advice to researchers and supports the best outcomes when working with Aboriginal and Torres Strait Islander communities. So there is a limitation in Aboriginal and Torres Strait Islander representation from a remote community level. So there's many factors that impact women being able to travel in to attend meetings, but it's also important that, you know, we make space for them within our research. It's important to be able to include community voice at a remote level and give voice back to community to set their own priorities and identify their own issues impacting their communities. So our future work is to travel out to remote communities where we build strong relationships with women and create a culturally safe space for women to engage and yarn about what's important to them and their communities. So the partnership has demonstrated right ways of working by incorporating an advisory group into decision-making processes, but also giving voice back to communities and allowing communities to set their priorities. Since the advisory group has been going since 2017, it's only now that we're actually seeing the impacts of this governance group within the partnership. Change takes time and needs persistence, and if you continue working for what you believe in, then you will see positive change. You will see systems change. I take comfort in knowing that we are achieving positive outcomes and creating opportunities for Aboriginal Torres Strait Islander people within research, and there's a strong leadership, you know, from our advisory group members, and they've played a huge role in ensuring community level voices are shared and lived experiences are highlighted. Yes, research is important. Oh, thank you. She knows me too well, this girl. So yes, we know research is important, but we need to create a platform for our people to share their experiences so others can learn and take control of their health and feel empowered to do so. Let's smash this stigma attached to diabetes. Let's break this cycle of silence when we talk about diabetes. Thank you.
Thanks, Sian. And so in keeping with the contribution that we really want community members and the advisory group to have on the work that we're doing, when we were planning this afternoon session and coming up with the questions, we wanted to take that back to the advisory group and look at what were the issues that had been identified in all the research that's been done about what were the issues that people living with diabetes thought were the most important. We've often, I think people in this room have probably sat in multiple workshops, stakeholder engagement meetings, about to try and come up with new solutions or outcomes or action items to deal with the impact of diabetes. But we really wanted to find out, and those workshops are often driven by clinicians, so we thought it was really important that we go to listen to the voices of the people that are living with diabetes. What are the things that have made the most difference to your journey that you want to see change? So we asked them, and I need to move this slide forward. So we asked them what were the most important issues, and they came up with stigma around diabetes itself, but also weight in particular, intergenerational trauma and racism, and then raising awareness. And when I heard that they were the issues that they wanted to talk about today, sometimes you ask a question and think, ooh, that's a hard answer. But then I was really excited that we actually asked the question, because if we hadn't asked the question, we might be talking about the same things that we've talked about in other meetings. These are the issues that are really impacting the lives of the people with diabetes today. And most of the people in this room sit in positions of power within their organisation, or are in a position of privilege because of the education that they've had or the life that they came from. And so with power and privilege comes responsibility, and with responsibility comes tackling the hard questions as well as the easy ones. So in our conversations today, there might be some uncomfortable moments, but we need to move through that if we're going to come up with real actions to combat the issues that are facing people today. Today's also going to be challenging because we have to run a workshop with over 200 people in one room and have tabletop discussions that are interactive. So we're going to be a bit prescriptive in the way that we do it. Each session will have a presentation at the beginning, and we'll then, following that, clearly articulate the questions that people are going to talk about. The way that we're going to give feedback is, because we can't have 26 tables give feedback all at once, and we would be here for a long time, we are going to draw numbers out of a hat. A very appropriate hat, an Alice Springs beanie, so that each table will get a turn to share their answers. But then if there are other people who feel like they've got something significant that they want to say that's been missed out, then by all means you can jump up. We really want, when you're coming up with your solutions or issues, that you really focus on solutions or action items that are in your sphere of influence. So I think we can often come up with big pie in the sky, and it's important to have those discussions. And there will be other times, in this workshop, and we've been in this weekend. Sorry, in this 2 days. There'll be other times to have those discussions, but today we really want you to focus on things that are within your sphere of influence or locus of control. So then we will feedback. And I guess putting my NT health hat on, so the values of NT health are safe, kind and responsive, and so we really want you to be mindful of those values when you're having the discussions around the tables as well.